those who want it, but those who need it, let the lenacapavir go to them. In the longer term, we will need to invest in our own regional manufacturing and innovation. Our continent carries 25% of the world's global burden of disease, yet we contribute just 3% of the world's medicine manufacturing. That's a huge inequality. We have enormous potential. I was so pleased in May this year when the Global Fund procured a first-line HIV treatment produced in Kenya and now saving lives in Mozambique. Brilliant. long-acting injectables are driving prevention, yet the pandemic persists and progress is uneven. Africa, home to over 2/3 of the global HIV burden, continues to face profound disparities in access and outcomes. While the 95 targets are within reach for many nations, others remain far behind. In Ghana, around 65% of people living with HIV know their status, and many are receiving life-saving treatment. New infections have steadily declined, and community-led organizations remain the backbone of our response. However, we must not forget that these gains are fragile and reversible. They demand sustained political, financial, and social commitment. Young people, especially adolescent girls and young women, account for a disproportionate share of new infections. Stigma and discrimination remain barriers to testing, disclosure, and adherence. And then comes the difficult test: financing. With global support shrinking, Africa must refuse to let her hard-earned gains unravel. This is our chance to be bold, to rethink, redesign, and rebuild a sustainable financial foundation for the next generation of health security. Distinguished delegates, if Africa is to end AIDS, and I agree with you, we can end it, we must lead our own response. We must strengthen domestic financing, build regional pharmaceutical manufacturing capacity, enhance disease surveillance and laboratory systems, and empower communities and civil society organizations. Earlier this year, Ghana convened the Africa Health Sovereignty Summit to chart a new path for sustainable financing, domestic manufacturing, and resilience. The message was clear: Africa cannot outsource her health security. Our national approach is anchored in our broader research agenda. This is a long-term strategy to build a self-sustaining, technology-driven, data-enabled, and equitable health system. And its pillars are the following three. 1, sustainable and predictable financing. A national HIV response sustainable roadmap is being developed to secure domestic financing and strengthen accountability. 2, strengthening universal health coverage. Government has uncapped the NHIS to expand physical space for essential health services. 3, what we call the Mahama Cares, a lifeline for chronic conditions. The Ghana Medical Care Trust Fund provides support for citizens living with chronic and lifelong conditions. 4, free primary health care. This initiative, to be launched in January 2026, will guarantee access to essential services for every community, decentralizing care and removing financial barriers. And 5, local pharmaceutical manufacturing. A feasibility study is already underway to enable local production of HIV commodities, vaccines, and essential medicines, thus reducing dependency on external suppliers. Ladies and gentlemen, prevention must remain at the heart of our strategy. We must invest in behavioral interventions, scale up HIV self-testing, expand targeted programs, and prepare to adopt innovations such as the long-acting PrEP. These can change the trajectory of the epidemic, but only if Africa strengthens regulatory and self-delivery systems. Our communities have been the engine of our progress. Therefore, we must strengthen community systems, empower youth-led organizations, and center affected populations in decision-making. Thank you. HIV, TB, and even malaria are economic threats, and Africa cannot compete globally with a weakened workforce. The private sector must therefore be an active partner in manufacturing, logistics, digital health, wellness, and of course, finance. The next 5 years are the critical window that will determine whether we can reach the 2030 target of ending AIDS as a public health threat. We know that this is Africa's decisive moment. We possess the science, the knowledge, and the leadership, and of course the resilience. What we need to bring to the fore are unity, consistency, and the courage to prioritize sustainable solutions over short-term fixes. Let us advance our focus. Let us advance our focus on discipline, scaling integrated, sustainable responses that can end AIDS, TB, and of course malaria too, and position Africa for long-term health resilience. Once again, on behalf of His Excellency the President, I welcome all of you. Enjoy the hospitality of our people. I welcome all of you to ICASA 2025. And I want to thank my relatives, the Nigerians, who I know they are here, for admitting that the best jollof from the continent is found in Ghana. Thank you very much and have a
Thank you very much indeed. I'd like to invite the First Ladies to join the Vice President to take a photograph. We'd also want to invite all the SAA board members to join the photograph. I believe they would come down to the steps. Head of protocol, please direct the photographs. We'll just take 3 quick rounds of photographs. The first one, the First Ladies with the Vice President will take the first one, and then all SAA board members, and then all ministers and reps of countries will take the third one. So all SAA board members. So after this round, all SAA board members, please come forward now. Yes, all board members, please come forward and join the Vice President and the First Ladies. All SAA board members, please come join them for the photo now. Let's be snappy with this. Thank you. When we're done, we will invite all ministers of health and former ministers of health to take one last photograph with the Vice President. All ministers and former ministers present. So this is the second group photograph for all SAA board members. Thank you very much. We now invite, thank you SAA board members, you may take your seats now. All ministers of health, deputy ministers and other ministers present, please join. Dr. Yes, please join us, sir. Former Minister for Mali, and also all the names mentioned in the first round of acknowledgements. Heads of UN institutions and HIV/AIDS institutions, country reps. If you're a country rep, please join this final photograph. Country reps, heads of critical institutions, and country reps. Some of you may climb up. When we're done with the photographs, we'll all go back to our seats. The police band will render the national anthem, after which the Vice President will leave us but we have a session right after this to be delivered by the Executive Vice President of AHF, Dr. Peninia Lutung. She should be on standby. Introduction of the session to be done by Ambassador Ekuasena Dansua. Thank you very much for the photographs. Please go back to your seats. We'll be upstanding for the national anthem of the Republic of Ghana. I'd like to remind us that the sessions do not end after the departure of the Vice President. Dr. Lutung of AHF, please be on standby together with Ambassador Ekuasena Dansua. Let's all remain standing as the police band leads us in the national anthem of Ghana, after which Her Excellency will depart from the conference. Thank you. Remain standing, Your Excellency. Thank you very much for attending upon the conference. ICASA 25 is happy for your patronage. We will remain standing. The dance ensemble will lead this brief interregnum as the Vice President departs. We'd like to invite Dr. Peninia Lutung to get ready to take over the session. Ghana Dance Ensemble, please come and accompany the Vice President as she departs from us. Ambassador Ekuasena Dansua, please get ready. Conference is not over. We will resume in 5 minutes.
The session continues. Please stay with us. We have another interesting discussion that is going to take place very shortly. May I request that we settle down and get started with the next session. May I request that we get started? The next session is very important for Africa. The next session is very important for Africa and it's to do with health financing. Okay, so as we settle down, may I get your attention? the honorable ministers here present, dignitaries in your various capacities, distinguished ladies and gentlemen, all protocol observed, good evening. I'm called Dr. Penina Yutung. I'm the Executive Vice President for AHF's Global Programs. The AIDS Healthcare Foundation Global Public Health Institute partnered with the CASA 2025 to hold 2 high-level summits on regional health leadership and sustainable financing for Africa. Our keynote speakers were supposed to be His Excellency President John Mahama of Ghana and His Excellency President Felix Tshisekedi of the Democratic Republic of Congo, but because of their conflicting schedules, they were unable to join us. However, we will still hold this important session. We will now merge this session with another one and focus on the topic, sustainable and innovative financing for regional and national security, where our Ministers of Health and Finance, Minister from Finance and representative from the Africa CDC will address us. So as we now open, I'm going to invite Honorable Ambassador Akua Dansua, who is the chairperson of the Local Government Service Council here in Ghana. She is also a global health advocate and a 3-term member of parliament. She has served her country, Ghana, as a Minister for Women and Children, Youth and Sports, as well as a Minister for Tourism, and as well as an ambassador to Germany. I welcome her to the stage as we open this session, following which I will welcome the key speaker. Thank you.
Thank you very much, Dr. Penina. Good evening, everybody. Good evening. Thank you very much for your attention. Your Excellencies, distinguished ministers, colleagues, partners, and friends, I'm extremely happy to welcome you to this critical conversation on sustainable and innovative financing for regional and national security, a discussion that sits at the heart of Africa's pursuit of true health sovereignty. Coming immediately after the powerful African Health Sovereignty Summit in Accra, and especially the fireside chat with Excellencies President John Dramani Mahama of Ghana and President Felix Tshisekedi of the Democratic Republic of Congo, this session invites us to move from vision to implementation and from political will to practical mechanisms that ensure Africa can finance, sustain, and protect its own health future. Across the continent and the world, we are navigating a moment defined by both extraordinary opportunity and unprecedented pressure. Donor funds and traditional official development assistance are shrinking, even as the burden of disease, democratic transitions, and the frequency of health emergencies continue to rise.
Please, can we take our seats? We want to continue our session. Please, can we settle down? Can we please settle down so that we hear what the speaker is saying? Michelle Sidibe, please, can we settle down so that we can understand each other here? Thank you so much. Thank you. Board members, yes, the one with the hat, please. So that what's being given to us by this speaker becomes valuable to us. Yeah. Thank you. I think people have settled. Thank you so much.
Thank you, sir. Let me restate that across the continent and the world, We are navigating a moment defined by both extraordinary opportunity and unprecedented pressure. Donor funds and traditional official development assistance are shrinking, even as the burden of disease, demographic transitions, and the frequency of health emergencies continue to rise. At the same time, Africa's debt crisis has reached a dangerous point, with the continent projected to service nearly $80 billion in debt this year, meaning that in many countries, more resources flow outward to creditors than toward health or education, among others. This imbalance is not just an economic issue, it is a public health threat. When physical space collapses, so does health preparedness. We meet today with a renewed sense of possibility because at this year's UN General Assembly in New York, Ghana's visionary leader, President John Dramani Mahama, introduced to the world the Accra Reset, a bold framework that calls on developing countries to reimagine global governance, build self-determined health and development systems, and move decisively beyond aid dependency. It urges us to do three simple things. 1, shift from endless targets to workable business models for health financing. 2, move from forced consensus to mutual interest, where African nations and regional institutions collaborate based on shared priorities. And 3, replace low-trust stalemates with co-creation and joint investment, bringing governments, development banks, private sector, civil society, and innovators into the same room, around the same table, and with the same commitment to results. This precisely is what sustainable financing for regional preparedness requires. We have already seen inspiring progress. Countries across Africa are strengthening domestic resource mobilization. They are exploring innovative financing models and building regional manufacturing ecosystems to reduce dependence on external supply chains. Institutions like the African Union, the Africa CDC, and the African Medicines Agency are demonstrating the transformative impact of regional leadership. They are coordinating, Institutions like the African Union, the Africa CDC, and the African Medicines Agency are demonstrating the transformative impact of regional leadership, coordinating responses, mobilizing political commitment, and shaping a future where African health priorities are defined by Africans. But we also know that our ambitions cannot be met solely through government budgets. This is why today's conversation is so meaningful. If we are to build resilient, equitable, and self-reliant systems, we must strengthen coordination between the actors who carry the core responsibility for health financing and regional preparedness. These include our ministries of health and finance and regional institutions such as the Africa CDC. Our panel this evening brings together leaders whose collaboration is essential to expand physical space, improve efficiency, and secure the long-term predictable resources required for preparedness, prevention, and the protection of our populations. This panel is therefore designed not only to diagnose the challenges, but to propose concrete and Africa-led solutions. We look forward to hearing from how countries are moving from declarations to durable action, how financing models are evolving, and where the continent still has untapped potential in efficiency, in collaboration, and in new sources of capital. Excellencies, distinguished ministers, partners and friends, the Africa leadership model shows us that Africa does not lack vision, talent, or leadership. What we need is sustained investment, innovative thinking, and collective action that matches the scale of our ambition. With these thought-provoking introductory remarks, I invite Dr. Penny to moderate the session. Thank you very much.
Thank you, Ambassador Kuo. Ladies and gentlemen, it now gives me great pleasure to invite a distinguished panel of our leaders to address the topic Sustainable and Innovative Financing for Regional and National Security. We will discuss the Africa Leadership Model as a blueprint for regional preparedness. Please join me in welcoming the following panelists to the stage. Our first panelist, Honorable Dr. Cassiel Atoba Fosun, Minister of Finance, Ghana. A brief bio is that he's a lawmaker in the Parliament of Ghana. Professionally, he's an economist, a chartered accountant, and a tax practitioner. Welcome. I'm not sure he's here. Our second panelist is Dr. Muhammad Ali Pate, Coordinating Minister of Health and Social Welfare in Nigeria. Dr. Pate is ably represented here by Dr. Temitope Ilori, the Director General of the National Agency for the Control of AIDS, NACA, in Nigeria. She has served as a senior lecturer in the Department of Community Medicine at the College of Medicine, Ibadan, and as a consultant family physician at the University College Hospital, Ibadan. Welcome. Our third panelist is Dr. Aaron Matsoledi, Minister of Health for South Africa. Dr. Matsoledi has also served his country as a Minister of Home Affairs and Minister of Health before. He's also a member of the ANC. He's also a member of the African National Congress and a member of the National Executive Committee. I'm not sure if he's represented here. Our fourth panelist is Honorable Dr. Samuel Roger Kamba, Minister of Public Health, Hygiene and Social Welfare from the Democratic Republic of Congo, a seasoned health professional with over 30 years' experience in pediatrics and public health. Dr. Kamba has served his country in various positions, including as the Special Advisor to the President of the Democratic Republic of Congo, in charge of universal health coverage. Welcome. Our fifth panelist is Honorable Dr. Benjamin Hokpatnin, Minister of Health of the Republic of Benin. Dr. Benjamin has served as a coordinator of the Regional Program on Reproductive Health and HIV Prevention in the ECOWAS region within the Directorate for Mother and Child Health, and also in the humanitarian field. He's a gynecologist who has been deeply involved in the fight against obstetric fistulas and with special interests as well in breast cancer, cervical cancer, and violence against women and girls. I'm not certain if he's here. Last but definitely not least, representing the Director General, Dr. Jean Kaseya of the Africa CDC, is ably represented here by Dr. Benjamin Dodabaye, Acting Director General for External Relations and Strategic Engagement at the Africa CDC. Prior to joining the Africa CDC, Dr. Benjamin was a Senior Health Officer for HIV and AIDS, tuberculosis, malaria, and other infectious diseases at the African Union Commission. Welcome our panel. Thank you. Welcome, distinguished leaders. I would like to start introducing the first question that will go to Dr. Benjamin from the Africa CDC. Sustainable financing is the engine for achieving health sovereignty. How can regional models for investment and collaboration transform public health financing across the continent? And how have regional institutions like the Africa CDC demonstrated success in advancing these approaches? Thank you.
Thank you very much, and it is an honor to be here to represent the Director General of Africa CDC. So we are talking about a very important topic here. Health financing is a strategic investment. So we gather here at a pivotal moment for our continent. Over the past decade, Africa has made extraordinary strides in disease control, workforce development, and building the institutions' need for health security. But today, we are facing a lot of threats. Outbreaks are rising for 41% between 2022 and 2024. And our...
Just a minute, we are getting some feedback. Could we get some help from the IT team? We are getting some feedback from here. Thank you.
Hello? This is better. Okay, good. Sorry, I was threatened by the mic. Huh? Now, I was saying that outbreaks rising from 41% between 2022 and 2024, our financing capacity has collapsed, and the external aid has fallen by 70% since 2021. So why this moment is important? For us, investing on health is critically important. The difference is the sovereignty. That was say, when 70% of health spending relies on external donors, our decisions are not are not ours. So we cannot afford to wait. Now coming to the Africa CDC role, as you have requested, is that in April 2025, Africa CDC launched two-phase strategy to make health independence a reality. The phase one is about piloting and proving. The phase two is about scaling and sustaining. So the phase one, in terms of piloting, especially in 30 countries, it is to update national health financing plans in 30 countries and testing innovative revenue mechanisms like airline levies, although controversial for some countries, health levies on mobile services, solidarity contributions, and establishing transparency dashboards to track progress and build institutional trust. Launching the Africa Health Financing Scorecard to measure implementation, but not just intentions. So we are not imposing a one-size-fits-all approach. Each country will customize mechanisms that fit its political and economic revenue base. Now the phase two is to scaling for impact. The goal is to enable at least 20 countries to finance 50% or more of their health budget through domestic sources by 2030. Regional policy harmonization through financing hubs are very important, and the scale-up successful pilots discontinue what does not work. So by 2030, Africa will have proven that health sovereignty is achievable, and by 2040, it will be the norm. So let me pause here. Thank you.
Thank you very much. May I invite, yes, please comment. I'll repeat the question. Sustainable financing is the engine for achieving health sovereignty. How can regional models for investment and collaboration transform public health financing across the continent? Thank you.
Thank you very much. Well, in Nigeria, just to put on record, Nigeria is the most populous nation with black Africans. We have a population of over 200 million. However, we are on the track. We have not achieved the Abuja declaration of 50% yet, but we have a national framework that we're working with, part of which is to increase budgetary allocation, both at the federal level and at the state level. Nigeria is the federation of states, 36 plus 1 state, and 774 local governments. We, at the federal level, we are working with the sub-nationals to ensure that budgetary allocation is increased. We are also, I must give it to Ghana, though, that they are a big brother in terms of national health insurance scheme, though I do not concede to the fact of Jollof. I think we're still the owner of Jollof. But I must give it to them, because unfortunately in Nigeria, we have just about 10% of our population at present on the National Health Insurance Scheme, which we're expanding now to include more people. In the last 1 year, we've been able to onboard over 2 million Nigerians on the scheme, as well as onboard vulnerable people, pregnant women, on the 5 children, and even people living with HIV now. We are onboarding them across the 6 states of the Federation. That is one aspect. We are also ensuring efficiency in our programs by integrating key programs. This is work in progress to ensure that we eradicate verticalization as much as possible. Aside this, we are also renovating and revamping our primary healthcare facilities, knowing that primary healthcare is the bedrock of any health sector. So we've been able to channel resources, not only infrastructure, but also capacity building of health workers. I must say, though, that we're suffering from the slogan, or is it the word JACPA? I don't know if people in the audience have heard about JACPA. That is the massive migration of health workers from low and middle income countries, Nigeria in particular, to the health high income countries. But to be able to mitigate against this, we are expanding our training health institutions. We are training more people to fill in the gaps, and we are recruiting more health workers to fill in the space, even as we train and retrain them. In addition to this, the federal government has introduced what we refer to as the Presidential Initiative in Unlocking Value Chain, PVAC. And what that does is it's source for resources, source for collaborators, source for investors in the health sector to collaborate with us in the health sector. We've been able to sign a few MOUs. Feasibility studies are ongoing to ensure that some of our health commodities are being produced in Nigeria. We have mosquito net, for instance. We're talking to local manufacturers that already have transfer of knowledge, from partners in China, in India, to be able to produce antiretroviral medications and other commodities like rapid diagnostic test kits. These are a few strategies that we are adopting. Thank you.
That's very good to hear, Dr. Ilori. As a follow-on question, you already touched on the aspect of Africa having made declarations to allocate 15% of each country's national budget 24 years ago. And then 6 years ago, in 2019, the Africa Leadership Meeting pledged to further increase domestic investment in health. We know that many countries in Africa are not allocating the 15%. But in listening to you say Nigeria is making some strides in that direction and is doing more to invest in health, I would also want to hear if you could address the same question. How do we move from declarations we've made in the past to concrete action? Thank you.
Thank you so much. Good evening, everyone. I will write on existing protocol. I know I was set to be representing my Honorable Minister. My name is Dr. Thembisile Kulu. I am the Chief Executive Officer of the South African National AIDS Council, and I also chair the Global Fund CCM in South Africa. I'm proud to say that moving from declaration to action, South Africa is a good example in terms of where we stand at the moment, where close to 80% of our HIV program is funded from the national fiscus. So it is exchequer funding. And it really has been exciting to see many of our African countries beginning some reforms in terms of their fiscal policies. And we are also witnessing a shift towards efficient and value for money health spending. This is where countries are prioritizing the move towards universal health coverage, strengthening primary health care, because every investment that we make in HIV is an investment in the systems that will move us towards universal health coverage, and South Africa is doing this through the National Health Insurance. Thirdly, I'm excited that South Africa is one of the 9 early adopter countries for lenacapavir as per the Global Fund policies. And one of the agendas that we are advancing is the agenda of health security, pooled procurement, and local manufacturing. Because I think we cannot repeat the mistakes of the past, where when global supply chains shut down, we find ourselves as Africa lagging behind. So South Africa has been working directly with Gilead to say, allow Africa to produce the drugs that Africa depends on. Fourthly, bolstering, I would say, our regional solidarity through initiatives like the African Union's leadership meeting, the Africa CDC's new public health order. And it's exciting to see that countries are mobilizing and coordinating financing for health. But colleagues, I would say commitments alone are not enough. We need to embed health financing within our broader economic growth strategies. We must invest in our people, who are our most important investment. And South Africa really stands ready to work with all the member states of the African Union and partners to make sure that we translate our continental commitments into measurable progress. So let's remember that declarations inspire, but actions actually transform. And today, Africa is choosing transformation. Thank you very much, Chair.
Thank you very much. May I ask that you answer the same question? How do we move from declarations to concrete action, considering that we had 24 years ago, we talked of 15% allocation of our national budgets to health. 6 years ago, the African Leaders Summit talked about investing more in health. So how do we move from those declarations to concrete action? If you could share some examples from your country.
So thank you very much. I think that I apologize because I will speak in French. So for people who understand French, it's very good, but
it's okay. It's
rather I apologize.
Yeah.
Donc je suis Dr Kamba, je suis le ministre de la Santé de la République démocratique du Congo. Et je voudrais d'abord rappeler à la communauté que c'est quand même nous qui avons décrit le VIH pour la première fois. Je crois que les gens ici ont déjà oublié un peu l'histoire du VIH, mais c'est quand même au Zaïre qu'on a décrit cliniquement le VIH et donc le sida. Et donc nous avons depuis lors parcouru un très long chemin, mais on s'est rendu compte quand même que dernièrement on était dans une injustice où nos enfants accédaient moins aux soins que les adultes, alors que les enfants sont des victimes. Et donc, il y a eu une initiative présidentielle, effectivement, qui est venue d'une autre leçon que nous avons apprise. C'est en regardant le taux de vaccination de nos enfants de manière générale, on s'est rendu compte qu'il était très faible et le président de la République avait impliqué tous les gouverneurs. Et on s'est rendu compte qu'en impliquant les gouverneurs, eh ben, on améliore les résultats. Et donc, le président de la République a réuni tous les gouverneurs de notre pays dans une province qui s'appelle le Lualaba, et il a fait cette déclaration, cette initiative présidentielle pour que nos enfants puissent rattraper l'injustice qui leur était faite à l'accès au traitement et même à l'accès au diagnostic. Cependant, au-delà de déclarations, effectivement, il y a des initiatives financières. Ce que nous avons, nous, obtenu en RDC, c'est que tous les gouverneurs montent leur budget de santé à 15%, le budget provincial, et c'est sur les 15%, 5% sont réservés au VIH pédiatrique. Et ça, c'est une différence notable dans le financement. Mais au-delà de ça, comme le VIH ne se produit pas tout seul, il est dans un environnement de santé, nous avons d'abord commencé à travailler sur la couverture santé universelle pour pouvoir améliorer l'accès aux soins, d'abord pour les mamans et les nouveau-nés, ça c'est gratuit, mais nous sommes en train de déployer maintenant le premier paquet de base pour les soins de santé primaire. Parce que il est souvent regrettable de voir une maman qui a accès aux maladies de VIH, mais qui ne peut pas se soigner d'une infection banale, parce que ces soins-là sont payants et malheureusement très difficiles d'accès. Donc permettre à tous d'accéder aux soins de santé primaire et donc favoriser l'accès aux médicaments pour les tout petits, je crois que c'est notre stratégie actuellement et au travers de l'initiative présidentielle, c'est l'engagement de la République actuellement.
Thank you very much. For the audience, if you need some translation, please scan the QR code so that we are all understanding each other. Thank you. I'll follow on with another question. Considering the strong connection between health and prosperity, what is the missing link in convincing financial actors, private and public, to prioritize investment in health as essential for socio-economic development? I've heard what you said governments are doing, but beyond just what government is doing, how do private actors, including the private sector, multilateral development banks, and regional health institutions, all contribute towards ensuring finances for health are increased?
Okay. Again, I will say it in French. So, je crois que l'investissement en santé, pour nous, doit venir de toutes les sources. Actuellement, d'abord, je parle du niveau public. Ce que nous avons décidé en RDC, c'est d'avoir une taxe, parce que pour l'instant, notre système de santé n'était financé que par le trésor public. Et on s'est rendu compte, bien sûr, que le trésor public seul, plus les donateurs, ça ne suffit pas. Et donc, le président de la République a décidé que nous allons avoir maintenant une taxe qui est de 2% sur tous les produits importés. Tout ce qu'on importe en dehors de ce qui est alimentaire, eh bien, cela va être taxé à 2%. Alors ça, c'est important parce que ça va permettre aux privés de pouvoir maintenant investir en santé en étant sûr qu'il y a une source de financement additionnelle qui vient effectivement du secteur public grâce à la taxe. Et cette taxe-là permet en fait, même d'ailleurs avec le retrait des partenaires, cette taxe nous permet en fait d'améliorer les ressources domestiques. Et donc, à côté de ça, nous venons de rendre obligatoire l'assurance maladie avec un prélèvement de 2,5% sur tous les salaires du secteur formel. Maintenant, le secteur informel, c'est un challenge sur lequel nous sommes en train de travailler pour voir comment ramener toute l'économie informelle, qui est quand même une économie, vers le côté formel pour pouvoir assurer cette assurance maladie obligatoire. Donc nous sommes en train de trouver le moyen comment faire le PPP, le partenariat public-privé, grâce à des ressources additionnelles qui nous permettent de faire des montages financiers et d'aider les privés finalement à investir plus facilement en santé.
Thank you very much. The beauty of technologies we can now follow. May I ask that you also address that question? Thank you.
Thank you so much. So I won't reflect on what Minister has reflected on, but I'll touch on two issues. I'll touch on the private sector's capacity, and people who were in this morning's session would have heard me say, our private sector has got resources and institutions for health that did not collapse when PEPFAR funding was pulled out. Many of us have got mines in our regions, and mines have got social responsibility not only to their employees but also to their peri-mining communities. And mines remain an infrastructure that can be utilized not only for providing resources but also to provide a differentiated service delivery model, yet they remain untapped in terms of how much we utilize them. And then I'd like to speak about the power of communities. Each time many governments speak, we are still grappling with the issue of social contracting. So we have not fully leveraged the whole of government and whole of society approach. I gave an example this morning again that South Africa was expecting a donation of cabotegravir from the US government, about 250,000 doses towards the end of last year. We utilized communities to get people excited to receive this 2-monthly injection, which was going to change the prevention trajectory. The donation never arrived. And now, with the introduction of lenacapavir, we need to use the same communities to mobilize our people to be excited about them. But yet, community trust is broken. The trust between governments and communities is broken, and governments need to strongly invest in social contracting to make sure that when we say community-led monitoring, communities are truly an equal and strategic partner in terms of the HIV and TB response. Thank you, Chair.
Thank you very much. May I ask that you address the question and then Dr. Benjamin.
Thank you very much. Well, I will also continue from where she stopped in terms of public-private collaboration partnership. We are proud to say that we have the richest African living with us in Nigeria, Dangote, and so many other rich people. So we do partner with them in the area of health, and that is one strong partnership we're doing to address that. And we are also partnering with faith-based organizations. You know, interestingly, there's so much money in faith, particularly in the big religions, the Christianity, the Muslim, and there are lots in NACA, National Agency for the Control of it. As we speak, we are mapping the health facilities across the Federation, and there's so much huge resources, so many facilities that they have that we can leverage on, and we can also collaborate with them. So we have a relationship and a collaboration that is ongoing to be able to address this. And we're also looking at taxation. It's already in the Parliament to see how we can tax sugary and carbonated drinks, to see how these resources, how this money can be used for health. As present, aside from the usual budgetary allocation, we have 1% of our national budget, consolidated national budget, going to what we refer to as the Basic Primary Care Provision Fund, and this is to address mainly the ATM, HIV, tuberculosis, and malaria across the Federation. But we are also looking at our best to increase this to at least 2% aside from the regular budgetary allocation. Thank you.
Thank you very much. Please bear with us. The sound here, there's a lot of we're not hearing each other well, so I hope you're hearing us. Dr. Benjamin, would you address the same question, please?
Yes, no, thank you very much. But there are key facts that we need really to address before we move into that one. Only 3 countries in Africa have met the Abuja Declaration. Only 3. And over 30 remain below 10%. That is a serious problem. The second fact is that Africa debt servicing costs, 81 billion annually, now exceed anticipated external financing. So that is squeezing our budget further. and only 16 African countries have, updated the national health financing plan. It's a serious problem. Now, moving to the solutions, we have, for instance, some key components that we need to consider. One, the domestic resource mobilization. That is extremely important, and all the countries that are represented here, they talked about it. But we need to move progressively, taxation and the fiscal space with a very good analysis. Otherwise, it will be extremely difficult if you impose a huge tax to some companies. Now, the innovative financing mechanisms, yes, we talked about them, but again, there is one area that remained completely intact, is the Africa, the diaspora remittances, and that is almost 95 billion annually. That represents a critical resource for health infrastructure investment in Africa. So that is extreme. Every dollar mobilized domestically is a dollar of independence. That is extremely important, and it will eliminate fragmentation and waste in health spending. And the regional, we need also to look at regionally what are the good examples that we need to learn from. It is very important, like if you take countries in West Africa here where we are, the good examples are coming from Ghana here. We need to learn from it. In East Africa, there is a country like Rwanda that has a very good example. We need to learn from them. So we have the solutions here on the continent, and we need to learn from each other. Thank you.
Thank you very much. You touched on something is important that I would want the other panelists to also address, if you can. The aspect of tapping into the diaspora returns. The Africa Development Bank, I think, say it was about over 95 billion annually is returned. That's more than the official development aid that we receive. So how can we get these members of the diaspora interested investing in health, and also just investing in the development of Africa? Anyone? My sister from Nigeria?
Yeah, thank you. Well, I would say the aim is to turn brain drain into brain gain. So we're working with the diasporas. We actually have a commission that is dedicated to diasporas. That is in Nigeria. We have a whole commission under the Ministry of Foreign Affairs. And because we appreciate the huge resources that come from there. So using technology, using innovation to see how, the exploits can actually be brought back into the system to assist, in building infrastructure, health infrastructure in the system, in starting factories, industries, and the like, and even in terms of knowledge transfer. We have a lot of collaborations with them. Some come over to act as adjunct lecturers, adjunct teachers in our health institutions, in our training institutions. So this we are doing to ensure that at least, though there are discussions around, which I think is good for us, even as Africans, to start discussing now. The high-income countries, up north, they tell us you need this percentage of doctors to the population. But they're the same people that come around to poach. I'm a lecturer. Before I became a DG, I was lecturing in the first and foremost university, which is University of the Bible. And I know every year, 85% of my students migrate to the high-income country. I think it's about time, as Africans, we need to sit down and have that discussion. If these people are working for you, what is in it for us? We train them with our resources, with taxpayers' money, especially for those that go to federal or government hospitals, they pay little to nothing. And then you poach them and take them away from us. So I think there's time we need to have that conversation and see how that resources can be brought back into our system to build, a very fragile health system. Thank you.
Thank you so much. So I will give an example of how I think the current situation in terms of how we treat our healthcare workers in our system now will determine the appetite of our healthcare workers that are outside of Africa to come back. And I'm going to give an example. When PEPFAR and other international agencies employed staff, they were not necessarily within government salary bands. They were earning way more in terms of other incentives. And there were no discussions between public service administration, treasury, and health in terms of how to absorb. But what South Africa has done after decades of war is to start with a policy where our Minister of Health has had, for lack of a better word, I won't say confrontational, but I'll say a strong conversation with the Ministry of Finance, and that has resulted in community health workers being absorbed into the health system. So how you treat your employees at present determines how forward-looking your diaspora is. And then secondly, some of the policies that we introduce in country, including the 6-month, multi-month dispensing, for instance, actually frees healthcare workers to focus on the sick patients. It allows healthcare workers to be taken care of in terms of their mental health because they focus only on the sick patients and not seeing well patients monthly. So there are certain policies that we are adopting to make sure that even from a mental healthcare perspective, we invest in our healthcare workers and we make sure that we care for the carer. And I have got no doubt that that is resulting in a lot of our diaspora considering coming back into our country. Thank you so much.
Mais je crois aussi que l'importance de la politique que l'on mène peut déterminer comment est-ce que notre diaspora, comment est-ce que nos ressources humaines peuvent se comporter. Moi, personnellement, j'ai pris mon bâton de pèlerin, je suis parti voir notre diaspora à l'étranger, notamment en Belgique et en France, pour leur dire de revenir. Mais ils nous posent la même question. Vous avez déjà beaucoup de prestataires de soins dont vous ne vous occupez pas vraiment. Comment voulez-vous nous convaincre, nous, de revenir? Et donc c'est très important, effectivement, d'améliorer déjà les conditions de ceux qui sont sur terrain, de montrer que ceux qui sont sur terrain sont considérés par les politiques que nous menons sur terrain, d'une part. Mais d'autre part, une autre question de la diaspora, c'est surtout le plateau technique. On va venir, nous ne pouvons même pas faire un simple diagnostic parce que vous manquez de tout. Et donc, investir dans les plateaux techniques donne la valeur au travail de la diaspora, au travail de ceux qui peuvent revenir. Et donc, ça leur permet d'avoir encore plus de confiance dans le système. Mais payer aussi cette diaspora-là, c'est pour ça que les ressources additionnelles, les ressources qu'on peut faire venir au-delà de salaires qui sont souvent très faibles, ces ressources sont très importantes. En tout cas, en RDC, comme j'ai dit, nous avons créé 2 taxes, une taxe sur les importations et une assurance maladie obligatoire, entre autres choses, pour améliorer les conditions des prestataires de soins. Les distances aussi sont vraiment un problème. Quand on est dans des conditions rurales comme les nôtres, où 60% de la population est en milieu rural, c'est très difficile de convaincre les gens d'aller dans les milieux profonds. Mais cependant, si la politique générale est bien menée, je crois que les Africains sont capables de s'occuper des Africains.
Thank you very much, distinguished panel. And as I wrap up, it's very good to hear the examples of what is working in the countries and commitments that are coming from the African governments to improve health financing. But as Dr. Benjamin said, it is not enough. Only 3 countries are meeting their commitments for Abuja. However, we see that there is an effort being made in ensuring that the national health insurance schemes, revamping primary health care, and also investing in universal health coverage, embedding health financing as part of investments in prosperity. You've also talked about how you are involving the private partnerships, in building public-private partnerships in all avenues, so that they are also dedicated to supporting the health budgets. We talked about the areas of of taxation, like in DRC, that is allowing dedicated funds to be availed for health financing. That said, we have so many examples in individual countries. I'm hoping that through Dr. Benjamin here and under the African CDC and AU specifically, that we can embrace South-to-South collaboration, learn from each other, so that then what works in DRC can be implemented in another place, instead of working as, instead of working alone as countries. We can learn from others' experiences and be able to grow our health budgets based on what we see working in other countries. So I'm hoping that the African Union with its bodies can be to work with countries and help them learn from each other. Ladies and gentlemen, a rouse of a hand clap for this distinguished panel. Thank you very much for taking the lead this evening. Thank you. A group photo, please. Can I also invite the CASA team, AIDS Healthcare Foundation team for a photo? Thank you.
All right, as we look at the paparazzi, we have one more session, but believe me, this session is different. It is your session. Once the paparazzi is over, I hope that's in the Oxford Dictionary. Jackpot is already in the dictionary. Paparazzi should be in the dictionary by now. Would like to invite our last panelist to a very exciting session. I'm sure you have been hearing from the speakers about the need for regional manufacturing of vaccines and medicines. Hi, ladies and gentlemen. This is my section. I need quiet. 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 Quiet, guys, ladies, friends, best of you. Yeah. I'll be co-moderating the session. Hi. Hello. Let there be peace. Let there be peace. I'm just coming from Lebanon, and I took some blessings from the Pope. Let there be peace. Thank you. So I'll be calling on the panelists, along with my co-moderators, for the session that is looking at what regional production is all about. You've heard it over and over. We can't continue in the current, we have 25% of the diseases, yet we only produce 3% of all that is needed, vaccines and medicine. And we have experts that will be discussing this with us. Did you prepare the session? I have no idea. We won't go session by session. We'll just make it very, very brief. So we're going to call on our speakers, Dr. Darcy Dako. Oh, she's not in here. Oh, I was looking forward to seeing her. That's the DG, African Medicines Agency. So I'm going to sit you down for that session. Please, darling. It's very critical. He's the vice. They introduced him at African CDC, but he's not. Thank you, darling. Please sit down. Thank you, darling. Oh, you're going to sit down. You're going to sit down. This is the most important part of the session. Thank you, darling. Thank Thank you. Yeah. Please clap for him. Give him, celebrate him. We also have with us on this panel Nikai Ndembi from the International Vaccine Institute. He's one of the 100 times awardee in terms of excellent health. Celebrate him with me. Celebrate him, everyone. We have Alan Maleshi. Is he here or she? Apologies, I don't know the gender. Oh, good to see you. That's the lawyer with us. And we have one more panelist, Dr. Anna Amaya, who is a research assistant with the United Nations University Institute of Comparative Regional Integration Studies. Really nice to have you. I celebrate the one woman on this panel. That's one of my best. Yeah. Apologies, just a minute. Apologies. We have WHO Regional Director can't make it. As you noted, he had to give his gift. I'm just informed he has a representative. Please do come up. Oh, Mama. Oh, thank you. Apologies. Please let's celebrate her. Let's celebrate her. All right. Okay, friends. As you can see, we are the last panelists. And I don't want anybody thinking we're delaying their food. So I'm not going to go conventional. I'm going to do one thing. I'm going to give you 3 minutes to speak your heart to the topic. Any way you want to do it. But speak your heart to the topic. And then once you're done, I'm going to open it to the participants to ask the critical questions. Will that work with us? Excellent. All right. So I'm opening it up to each one of you. Don't worry. It's your work, and you are critical for the session. So I'm going to give you the last question. So I'm going to start from Alan. Please feel free for 3 minutes to speak to the topic, and then we'll go that round, and then we'll open it to the audience to ask the critical question. Alan, I'm going to ask you specific. Not Alan. African Medicines Agency, because it's very critical. I'm going to ask you a specific question. So over to you, sir. Thank you.
Thank you. And first of all, thank you for staying with us. I want to promise to keep this sharp, because the only thing longer than today's agenda has been Africa's wait for equitable access. So in my 3 minutes, I'm going to raise at least 4 points that are critical for us to think about vaccines and the issue of medical technologies and local manufacturing. I want to say that I'm speaking from a point of a person who is representing civil society and communities, and so my intervention is based on the lived experience of the people we serve, the people we represent, and the people that we work with. And it is important for us to remember 3 key things that I want to emphasize if we want to succeed on the issues of vaccines, access to medicines, access to technology, and diagnostics. The first one is the issue of equity. Equity must be designed in the system for vaccines and access to medicines. For long, Africa has relied a lot on charity and not guaranteed access to medicines and vaccines. And we all know the example of COVID. We were the last to receive, but we were the first to get travel advisories from other countries. When will that change? When will we see a change in leadership that ensures equity is part of it? The second point, which I hope Dr. Benjamin will address more, will be around the fact that regional regulatory alignment is absolutely important. We have an important agency called the African Medicines Agency, which is a game changer. But how many African countries have ratified to ensure that that agency is fully funded and working? Can you imagine the African Medicines Agency and Africa CDC sitting together and being able to plan the procurement for Africa in terms of medicines and in terms of what is happening? So that is where political will is needed. And most importantly, the third message is that communities are important. They are part of this, and they are part of the resilience. We keep saying that the communities are the first responders to health crises, but they are also the last defenders on health crisis. We have seen it in COVID, we have seen it in the HIV response, we are seeing it in Mpox. So whenever you come up with any design of medicine, be it lenacapavir, be it a good ARV, if you don't involve communities in the design and rollout, as my colleague from South Africa said, you lose trust. And when you lose the trust of the community, it doesn't matter how shiny or innovative your technology is, it will never succeed. And so you must invest in communities, you must build trust, and as my sister from South Africa said, for sustainability to happen, you need to invest in community-led monitoring. Lastly, as a lawyer, I cannot fail to talk about the law. We definitely need a lot of legal reform. TRIPS flexibilities are not only to be used in emergencies. Compulsory licenses are not only to be given in emergencies. Many countries in Africa have the ability to use TRIPS flexibilities, have the ability to do compulsory licensing, and we need to make use of that. If we make these four things happen, I can assure you that Africa will be leading its own initiatives on vaccines, on technologies, and on issues of diagnostics. So that is my heart, that is my plea to you. I hope you'll be able to act on those four things in whatever capacity you are in, be it a leader, be it a head of state, be it an advisor, be it my sister in WHO. I hope then we'll be in a position to ensure that we make that particular change. I submit.
Thank you very much. So I am Fiona Braka, and I'm the World Health Organization country representative to Ghana, representing Dr. Janabi, who extends his warm appreciation and support for this important discussion. Talking about local vaccine manufacturing, medicines and other products, this is at the heart of Africa's health sovereignty. And we have talked a lot about the lessons we learned from the COVID pandemic, where we realized that 99% of the vaccines that we needed were not on the continent, they needed to be imported. 70 to 90% of pharmaceutical supplies are also imported, not on the continent. And yet the continent has the talent, the continent has the scientific capability, and also the manufacturing base to be able to turn this story around. We have more than 650 pharmaceutical facilities that are operating on the continent. We have governments that have expressed political will and have already started to invest in local capacities. And we have partners. We have institutions, financial institutions, we have the European Union, we have philanthropic organizations, all these entities that have expressed interest. And so what is needed is how we harness all these strengths on the continent and be able to have a coherent and coordinated approach to building our own institutional capacities. What I would like to put forward is the role of regional institutions such as the World Health Organization, Africa CDC, the Africa Medicines Agency. What role can we play in this effort to scale up local capacities? One is the regulatory harmonization. Exactly. I believe that this is of interest not just to us as a continent, but also to the manufacturers. They would like to have a harmonized, cohesive way in which we are regulated, in which we are forecasting, in which we are building our harmonized approach here on the continent. And also the African population would like to have products they can trust, that are safe. And so regulatory harmonization is extremely important. We have the opportunity of the Africa Medicines Agency that is aiming to harmonize 55 countries around a regional harmonized approach. This is a historic opportunity, and as the previous speaker said, how are we supporting that as countries? As WHO, there is a long-term framework that for local production that has been endorsed by harmonization of our regulatory capacities, institutional building. We would like to see more countries gaining maturity level 3 for their institutions. And we also have good manufacturing practices, capacities that need to be built. All these undermine the efforts as a region that we can achieve. The other aspect I would talk about as a regional institution is the opportunities for partnerships, promoting partnerships with the range of interested stakeholders, so the donor agencies, but also the communities, how we bring communities on board to be part of these products that we are trying to produce on the continent. That will be extremely important. And finally, I would say that as regional institutions acting in a coordinated approach, we can support accelerated progress to building local capacities here in the region. Thank you very much.
Thank you very much. Thank you.
Thank you for the invitation, first of all. It's wonderful to be here. And when I was told that the conversation would be about not only regional approaches, which I could speak about regional organizations all day, but also specifically around representation and how the involvement of non-state actors can also be critical within regional approaches to build health equity and sovereignty. That's something that's been very close to my heart, that I've been working on for many years, and also something that we are really looking at within the study that I'm co-leading, currently looking at regional cooperation across 5 regions. And this issue of the involvement of civil society and academia has come across very strongly in all regions, including the African region. And I think it's an issue that regional organizations and regions in general are grappling with, mostly because of the result of these old paradigms where we previously thought that governments alongside global institutions could do it all and we didn't really need the voices of other sectors, as well as, secondly, the lack of embedded mechanisms for meaningful representation within these regional approaches. Within the current context, very challenging context, not just financially, but also a moment where we are re-examining global institutions, regional institutions, and national institutions, it's really important that we look inwardly as well. We've criticized for a long time how global institutions perhaps don't create enough space for civil society groups or other non-state groups. But we also need to make sure we're looking at regional approaches themselves, not just talking the talk, but also walking the walk. We know that in order to achieve health sovereignty, we need locally driven governance, inclusive decision-making power, as well as coordination across sectors. And within that, the role of civil society and research institutions is critical in ensuring that these decisions are localized, people-centered, as well as rooted in evidence rather than being top-down or donor-defined. And we also know that to have strong health systems and public health institutions, the involvement of researchers is crucial, not just because they can show us what the evidence shows within the local context or international context, but they also can point us in the direction of how to maximize resources and reach our goal of ensuring health for all. Research institutions are also necessary to operationalize sovereignty by supporting the expansion of regulatory capacity, local manufacturing where you need that scientific capacity, as well as financing. And so without these type of collaborations, it would be very difficult for institutions like the African Medicines Agency and Africa CDC to deliver on their mandates, such as full procurement, continent-wide product approval, and harmonized standards. And ultimately, these regional efforts need to be collective ventures, where academics learn how to engage with policymakers in a timely manner, and also health leaders are open to new ideas. We also know that the evidence shows that many times our health interventions don't work because we don't have sufficient community engagement. And this has clearly been the case in a number of health crises in the region, such as the Ebola epidemic, outbreak, cholera, mpox, and others, where we still see persistent mistrust, fragmented health systems, and weak community engagement, and these have all weakened epidemic control. So for this, the role of civil society is indispensable, not only to support community-led efforts, but also to counter this misinformation, reach marginalized groups, and above all, keep decision-makers accountable to their commitments. So ultimately, we know that sustained domestic investment in civil society and research institutions is necessary not only to maintain independence from donor agendas, but also ensure stability of expertise, preserve institutional memory, and prevent interruptions in essential services. And I'm optimistic. I think we're getting there. The current discussions around the new public health order, Africa's health security and sovereignty agenda, and the Accra reset are very promising in this regard, since they clearly redefine the need for not only new partnerships, and by new I don't mean just new collaborations, but also new ways of engaging with different actors across sectors. So again, I think the time is now to have these conversations and learn from our past mistakes in order to maximize the future of all of these important commitments. Thank you.
Thank you very much. Let's show appreciation. And then yes, to Nikai, straight from the heart.
No, good afternoon. Maybe I'm going to be lowering my voice here. No, so this is a topic really dear to my heart, and particularly when it comes to building a resilient health system across the continent. I think linking to the previous presentation, the first topic around domestic resource mobilization is fundamental if we're going to move this agenda on local manufacturing. So during those days at Africa CDC, we've learned a very hard way on how we can build these systems. The Partnership for African Vaccine Manufacturing was launched with very key enablers. We identified them. We know them. We need a good coordination. That's where we need these regional entities, continental agencies. We need a good idea of the market shaping. Who's going to buy all these products? Vaccines, therapeutics, diagnostics. We need financing. That's linked to that innovative financing. Thanks to Benjamin for that justice to that topic. We need R&D, research and development. We cannot be able to produce if we don't have actually a robust research and development ecosystem. All those underpin on that skills development. We need to train Africans. If we're going to get to 60% by 2040, we need to train that human capital to be able to drive this. We need IP and tech transfer, which is linked to R&D, infrastructure, regulatory systems. If we understand those key enablers, the discussion around local manufacturing is going to be very easy. But again, it's important that we put in a level of investment, domestic investment, to be able to drive this. Let me give you an example from where IVI, the International Vaccine Institute, we're actually contributing to the local agenda, the agenda of local manufacturing. There are two vaccines that are currently working on. You all know cholera. Almost 25 countries so far are experiencing outbreaks of cholera. Since January, more than 6,000 people die on this continent due to cholera. This is a preventable disease with a vaccine available, and that vaccine has been developed by IVI. So now there's no manufacturer on the continent capable of manufacturing cholera vaccines. Every time there's a global shortage of vaccines, So while we're doing now what we're doing now, we're moving this technology to Africa. BioVac in South Africa has gotten the technology, and then now we're able to transfer a first clinical trials on cholera vaccine in Africa. Then second, you all know the zoonotic disease, the Rift Valley fever vaccines. We are moving that to Afrigen in South Africa. We're going to do that for the 22 priority diseases that Africa CDC has developed with partners, all of you in the room, and being sure that the made in Africa vaccines is accepted globally. So again, thank you so much.
Thank you. Thank you. Thank you so much. For you, it's very specific because of your understanding of regional harmonization of the regional regulatory system. Every single thing that the four panelists have said hinges on this to make things smoother in terms of regional access. Just one or 2 points. How are we taking this forward in the continent? Thank you.
No, thank you very much. What you just mentioned, we can summarize it on what we can call self-reliance. But for that one to happen, we need 4 interlinked pillars. And thanks to Nikes, he mentioned it already. But the pillar number 1 is the demand, right? You need to know the demand on the continent. That is 1. 2, we need to go into innovation. Extremely important. 3, the regulation that we were mentioning. That is extremely important, and the investment. So the ecosystem on the continent, bringing Africa CDC, Africa Medicine Agency, the CFTA, the Commission itself, they need all to come together really to create a coherent framework to make it faster and less risky really to bring the locally made vaccines, medicines, and the diagnostics to the African market. That is extremely important. So let me just pause there.
Thank you so much. Thank you. Let's show appreciation to the panelists. Please, let's show appreciation to the panelists. We've heard words like equity, transferring technology, joint procurement, local manufacturing ecosystem, communities, cheap flexibilities, regional regulation, and capacity building. But if you put the cloud, if you form a cloud, the one word that came out very strongly is community engagement. I'm opening the floor now to the audience. I don't know if you have a burning question for our panelists. So I have number 1 there, I have number 2 here, I have number 3, any number 4, otherwise I'm number 5. Okay, thank you. Anybody moving the mic around? So we have 1, 2, 3, 4 is open, 4, and then I'm 5. Excellent.
My name is Dhananjay Tripathi. I'm the CEO of Atlantic Life Sciences, one of the vaccine company in Ghana. I would like to take this opportunity to thank the panelists for the very wonderful presentation and points. My questions are 2. I'll start with Professor Nikes from the IVI. Is there any, apart from the vaccine, the OCV you mentioned, and also other vaccines, is there any scope to work in Ghana under the IVI, any development which locally Ghana can produce any of the product? That's one question for Professor Nikes. I would also like to thank to the WHO, the country representative. Of late, the WHO had been doing a lot of good work, taking initiative. We wanted to know that with the emergence of the AMA, Africa Medicine Agency, what role WHO can play in terms of the WHO, PQ, or maybe any product produced locally in Africa. How, is there any platform in which product can be harmonized under the continent or the regional blocks, and any support can be given, because WHO, it has got its own time and requirement and it's very time-taking process. If we develop a product we want to commercialize, with the presence of the maturity level 3 countries in the continent, is there any reliance where the WHO can play a role with the AMA? Thank you very much.
Thank you very much. We'll take We'll take your responses before you go.
Thank you so much. So what I'm going to explain, maybe I will take it from a very simplistic approach. There are about 6 technologies for manufacturing. mRNA is the most promising and the one we all know during COVID because it was developed in 9 months. So it's pretty agile, it's flexible, disease diagnostic, you can do it for any disease. But so far it's not mRNA technology. It's the technology we developed almost 20 years ago, but we're adapting it for the African continent in terms of stability and ensuring that we can actually meet our own environment. That's the technology we're doing now. And also quite easily, because it's a really oral vaccine, and there are a lot of other things happening. The microbiome of African population is different. So we're adapting it to be sure that it's acceptable, the effectiveness is as equal as what we're looking at within the community. I think this is a disease where we require 2 doses, but so far, due to the availability of the supply, we only do 1 dose currently. So we want to be sure that a single dose, if we are actually going towards that, is going to be as effective as a double dose vaccine. So to answer to your question, no, it's not an mRNA technology vaccine. It's the old technology we're adapting to our current context. Thank you.
Excellent, excellent response. Yes, ma'am.
Thank you. The audio was not very clear, but if I got you correctly, you are asking what support can WHO give around the pre-qualification processes in country. So, as you know, a number of manufacturers, a number of countries will require that these products that are produced meet the WHO pre-qualification, which is a very rigorous process to ensure safety of the products that come out. So we work with the countries, or we work with institutions to look at their good manufacturing practices, which is a sort of starting point. Unfortunately, there is a plan that is developed, and through the process we help to continue to monitor how well they are meeting the requirements. Then the pre-qualification process as well. We are also working with the national regulatory authorities to build their own capacities to be able in countries to do some of this monitoring. And we are happy that on the continent we have 8 countries. I believe Rwanda was the most recent one added that reached maturity level 3. And we are working with other countries to also build their institutional capacities. But bottom line for the pharmaceutical companies, the manufacturing standard according to the good manufacturing practice. And we work with you to do the assessments, but also to train and build the skills that are needed to do this in the countries.
Thank you very much. Excellent. From number 2, one question from number 3, and one question. And then they'll read one after one. Thank you.
Sure. Moderator, and to our speakers. My name is Diana Tivesigwa. I work with the AIDS Healthcare Foundation. And my concern is about the manufacturers themselves.
Who are you directing your question to?
Any of them, any of the experts.
You have to find one person.
Okay, the first one in a blue suit.
Okay, sir.
Oh, yes. So when we talk about manufacturing, we are talking about private sector. And we know that where they invest, they expect profit. So how are coming in to ensure that we facilitate them to have enough credit, because it's one of the hindrances that they have in production?
Okay. Actually, the voice is bad. Just recap, because Benjamin didn't hear you. Yes, just recap briefly. It's actually echoing. I tell you, the sound is very bad here. So, but he's obviously not heard you. Just recap briefly.
Okay, can you hear me now?
We'll hear it.
Yes, we are talking about manufacturers and we are talking about private sector. When you talk about a manufacturer, you're talking about private sector. And one of the challenges that are limiting their production is access to credit. And we know that people who are providing credit for a long time have not been considering health because they don't think there is a return. So how are we preparing to ensure that we have easy access to credit to facilitate? Yes.
All right. Thank you. Benjamin, you're on the spot about credit access to the private manufacturers. But in case if you can take it, anybody that can take it. Number three is there. Number three is there. In the case, you just put the practical experience in terms of how you mobilize resources to support private manufacturing. Okay? I think that's the question.
Thank you very
Private
much.
sector.
My name is Blessing Bolia from Zambia, and I'm the regional chairperson for the Youth Sharp Group, working around supporting healthy adolescents' rights and protection in the Great Lakes region. My question is directed to Dr. Benjamin. I would like to start by first appreciating the sentiments that were shared, especially around domestic financing and also just the issue of locally producing our medications and prevention mechanisms for HIV and SRH-related diseases. My question is, in line with regulation, local manufacturing, and private-public partnership, how should the sustainability landscape look like to ensure that these three coexist, coordinate, and local manufacturers are able to produce at a cost-effective rate that is going to be accessible for consumers? And how then are we able to leverage on local herbal medication to make this a reality?
Thank you. All right, that's 1.5 questions. Now, number 4.
All right, thank you very much. My name is Martin Mary, CEO for Kids and Teens Resource Center. I will be directing my question to Alan because he's in the civil society. I think our leaders in Africa are feeling too comfortable. What prayers can we mount to hold them responsible in achieving this at the region? Over-dependent on the Western and credits, I think it's not a way forward and it's not sustainable. We've just had a heartbreak recently, early this year. So what can we do to hold our leaders responsible? We have the resources to manufacture locally, to produce locally.
Okay.
What can we do to begin to make young people look into this direction right from now, so that the best time to plant a tree, they said, is 20 years ago?
All
when
right.
can we start that?
Thank you. So I give you my space, but it's a swap. You're going to have to give me something in return. I had a burning question. So let's ask question 5, and then the panelists answer. And if you don't have, I'll ask you question 5.1. I have something.
Thank you. I'm going to steal this opportunity to ask 2 questions.
1 question, just one.
One. Thank you. I'm Dr. Kate Samula, and I work with AIDS Healthcare Foundation. My question is to the panel, because I think it applies to all. Who will take the lead to ensure that we have alignment of vision and avoid duplication and competing manufacturing?
Excellent question. Excellent question. I'm going to ask Benjamin as African CDC to respond this time. Okay? So who's going to take leadership of coordination on the continent? Otherwise, we might see what happened in the early days of HIV. Everybody's running. And yes, so that would be. So we'll answer all the questions, and then I'm going to ask my own last question, and that's to you. And this is because issue around traditional medicines. We're here in Africa. I want you to share your thoughts on what it means to bring traditional medicine onto this platform, or traditional response onto this platform. When we're talking about regulation, you know what this is all about. Thank you. So let's have our panelists respond. For everyone that the question is directed at, we'll start with Benjamin, then Ikais. I think everybody had a question, and we go that route.
No, thank you very much. Let me start with the first and the burning question on the financing, right?
Yeah.
That is a very interesting question, but you know, first you need to define the specific manufacturing segment that and the needs, because you know the resource pathways are different. When you want to do APIs, it is not the same when we want to do vaccine, diagnostics, or supplies ancillaries. So we have first and foremost to define. And for each, we need to outline the investment case, the market size, the import substitution potential, the public health impact, etc. So we need to look at all these things. Now, on the continent today, we have the development bank that are financing today the manufacturing for health today. So African Development Bank, for instance, has committed multi-billion dollars envelope for pharmaceutical and vaccine manufacturing, and it is operationalizing the APTF. I don't know if you heard about it. The African Pharmaceutical Technology Foundation, that is based now in Kigali, Rwanda, to de-risk technology and IP access. That is very important. The second is AFC Bank, who has put also in place a dedicated multi-billion facility for healthcare and health product manufacturing on the continent. So these are the facilities that are today in place. Now on the coordination, to finish, you see each institution has its own mandate. So it is easy if each one understands its mandate. And the coordination, of course, can be done, you know, at continental level by the African Union, and everybody can support that one. Thank you. Over.
Thank you very much. Excellent. Nikais?
Yeah, for such an important agenda, I think you agree with me, it's an ecosystem, and every player has a role to really contribute into. So I think this is where the strength that we had during COVID should actually prevail as well. Good communication, good coordination, cooperation across the partners. But more importantly, how do we leverage on their comparative advantages? When I say R&D, there are very few institutions that can do discovery development. That's very important. We need to bring them around the table and have this conversation. So to the questions on financing for manufacturers, I can tell you during COVID, a lot of pledges have been made, billions of dollars for manufacturing, but less than 1% of those funding have been released. Manufacturing is not an easy business because it takes minimum, based on the Duke University's 5 years to get a vaccine WHO procured. I mean 5 solid years. So who or which investor is going to put billions and wait for 5 years to have the return on the investment? I think we just have to be patient and be sure our government can support the private sector. What we have done, we completed a survey landscaping. The current African vaccine manufacturing ecosystem is supported by the private sector, 90%. And the private sector are too patient. They are taking a lot of risk. We need to de-risk it by engaging government to put in resources into local manufacturing. That's the only way we can move. We have seen Korea, for example. The Korean government, 20 years ago, they only manufacturing 5% of their vaccine. Now they are manufacturing 70% because the government is putting 50% of the budget around the table to support R&D ecosystem. We cannot be reaching the 60% target if our government are not injecting enough resources for research and development to be able to get this vaccine off the road. It's not an easy business. The cholera vaccine costed us $25 million. It's the cheapest one. The typhoid vaccine costed us $25 million as well. It's the cheapest vaccine. So, but some of those will arrange around $100 million and $50 million. We're going to fund this. We need to be sure that we support the private sector to be able to do that. Innovative financing, the private sector, philanthropic organization, and all of us around the table to support this. It's important that we put it and inject funding in there. The 15% Abuja declaration, we have seen it, that didn't take the off the ground. We need that mechanism to be able to do this. I think this is for health security. It might be expensive at the beginning. If government put resources, maybe that would drop the cost. We can't compete with India. If India is manufacturing vaccine at $1 a dose, as we are now, we cannot compete due to the economy of scale. So it's important that this alternative financing instrument. So right now we are mobilizing resources and also engaging with member states to be sure that really they're buying into this idea. This is a concept that we can actually take all together to be able to move it. So now the sustainability plan is linked to that. If government owns this project, lead this project, it's Africa-led, I think I'm sure that it's going to be sustainable. Thank you.
Thank you very much. Thank you. Yes.
Thank you, and if I may, I will also concur with my colleague here in terms of the importance of not only government engagement, but more broadly political commitment, right? How are we going to make sure that these agreements are actually put into reality? And beyond just governments collaborating, I think we also need to think about the researchers and the research community creating these networks, and the evidence shows that works. The evidence shows across regions that that is where you build the capacity, but also you sustain long-term engagement and sustainable solutions beyond political cycles that are led, by the government in charge in the moment in time. So I think those long-term sustainable solutions are important, as well as engagement with the private sector as well, but also academia. So your question about traditional medicine, really important. We see that across regions as well, particularly in the South American region. They have been thinking a lot about that, and how it is not only related to regulatory issues across countries, but also related to grassroots sort of solutions to issues, and really maximizing local knowledge, right? And a lot of this is a question of how are we ensuring that we're not minimizing local experience, local knowledge, and making sure that those voices are at the table. And so for that, we need really clear mechanisms of engagement at the regional level that go beyond just nation states collaborating, but also how do we involve these other actors in the discussions. Thank you.
Okay, so on the questions around financing and also leadership, just to give two perspectives. One is from a global level, the opportunity of the pandemic agreement that was endorsed by the World Health Assembly earlier this year, which is building on the lessons from COVID-19 and trying to address, among several things, access gaps to ensure low-income countries have equal access. So aspects around cooperation in financing, in technology transfer, and capacity building, so that we build institutional capacity in low-income settings to be able to access, or at least have the technology transfer and have institutions on the continent be able to benefit from that. So from a global perspective, I think that's an opportunity. But when it comes to leadership, I think what will drive this is the leadership from the governments. And it's important that we, as partners, do support governments to take that leadership. One example that's been talked about today is the Accra Reset, the Accra Summit that was held last August. All this is driven by the fact that governments want to be in the driving seat in leading and building our own capacities around not just domestic financing, but local manufacturing capacities. So that's an opportunity. My last point is from the chair, just to explain a little bit, very briefly, what we mean by the maturity level that I have mentioned. So the WHO The WHO has the different maturity levels that are, we assess the capacities of national regulatory authorities, so looking at their capacities to be able to regulate, and so from a scale of 1 to 4, 1 being the most basic level and 4 being the highest. But if you get to level 3, you have built a system that is stable, that is well functioning, and that is a level we would like to aspire for most of the countries here on the continent. So, as I said, we have 8 or so countries currently, and a number that are working to build to that level. Thank you.
Excellent. Thank you.
So to the question about leadership, I'll look at levels. If you're looking at the Africa level, I'll definitely turn my eyes to Africa CDC and the African Medical Agency. Those are the two agencies that can drive issues of vaccines and medicines on the continent. If we come to the regional level, you're looking at regional economic mechanisms. The East African Community, you're looking at ECOWAS, you're looking at SADC. Those regional blocks must then play their role at the regional level. And of course, when you come to the national level, the leadership comes from the head of state and all the organs that they have. Those three need to work in a way that makes access to vaccines, technologies, diagnostics, and medicines a reality. To the question from my colleague from civil society, again, I look at it at 3 levels. At the national level, it starts with who you vote for. What have they promised you? Are they actually delivering it? If you vote for someone who has consistently not kept their promise about local manufacturing, then there's nothing much you can do. So your battle starts with the vote. But once you've done the vote, there are structures at the national level, such as parliamentary health committees that are supposed to play oversight around what has the government ratified and what has the government done. We need to stop applauding our leaders when they go to New York and sign declarations. We need to start asking, what have you done after coming from New York? Because that's where it stops. Yeah. But we don't ask them, what have you then done? And then we go for another unga, and then we go for another pledging ceremony, and nothing has moved. At the regional level, particularly at the AU level, we need to start a peer pressure campaign. If you're an African country and you've committed to local manufacturing and you've not done it, get a session at the AU and publicly explain why did you commit and why have you not done it. There's no sugarcoating. There needs to be some level of transparency. And then lastly, the role of communities is absolutely important. First of all, you must protect the civil space that exists to allow communities to litigate, to demonstrate, and to hold their leaders accountable. Without that political space being open, civil society cannot be able to play their role. So it is important that that space is created. And then with civil society, we need to continue to invest in monitoring that allows for the collection of data and making the data public for the people to be able to see where is my government moving. It's not an easy thing to do, but if we learn from the experience of what has happened with the HIV, TB, and malaria response, the question you need to ask yourself, has your government stepped up like the Ghanaian government that put money in their health budget as a result of the health cuts, like the Botswana government that put money more for HIV after the health cuts? So ask yourself, has my government actually discussed this? Has AU finally sat down and said, the funding from the West is decreasing? Are we dedicating a pool of money towards health for Africa? That is where the rubber hits the road. Thank you.
Thank you so much. Before I call on Dr. Sidibe to give the last word on this panel, what we've heard today is that the government of Africa is committed to 60% of its regional pharmaceutical need by 2040. We can start to count what 2040 is. And as at now, we are 3%. Believe me, manufacturing is not bread and butter. But we need to see communities, researchers, trainers, policymakers, regulatory agencies, finance sector, private sector all work together. And you as community can make a difference by speaking with the government. On that note, I'd like to welcome Dr. Sidibe to to, please? Yeah. All right, sir. You are welcome. Let's welcome Dr. Sidibe. You're welcome, sir.
Thank you very much. I want to just to start by saying that I was listening with a lot of attention. And I realized that one thing which is shocking me, being around for some time, like many of you maybe in this room, is that we are too much on a rhetorical discussion. Rhetoric. I don't hear anything here which has not been mentioned, which has not been discussed in many fora. What we need now is to move from rhetorical discussion to action. And I can tell you, creating AMA, we have been in 2012 already launching the ideas of creating a regulatory system in this continent. We have been pushing our leaders to take that decision. And it took us 5 months when they gave me a diplomatic passport of African Union for maybe 5 years to stay there to work on making sure that the ratification process can go on. In 5 months, we managed to get all those ratified. So I think what we need now is really moving from this rhetorical discussion to action. One, if you want to make that happening, I listened to a very excellent discussion. You need 5 pillars from my point of view. One, you will never make it without an integrated market. You will, with a fragmented market we have in the continent, I am hearing experience from India. India is a big market. I was there 20 years back. Peter Piotis, maybe he's gone, asking me to go there and trying to understand what is going on. Of course, the first thing was integrated market. The second thing is to guarantee, I want to insist to that one, guarantee internal demand. If you don't have a demand for any products and you're producing in, I don't know, in Senegal, and no demands outside of Senegal to make sure that you can really be able to sell, who will be coming to put his money as a private sector to really invest on that one? Because you don't have a demand. And I think the third one, you mentioned it, is to de-risk the credit. You cannot today, it's too risking. The risk is high for anyone who wants to invest in our continent today to produce vaccine or medicine, to be able to share that and to make it at the cost, at the price which could be accessible. And four, from my point of view, which is very, very important, is Africanized research and development. If you don't Africanize research and development and you continue with this approach and you think research and development is taken hostage by the North, and you want to have a discovery there, and you want to be able to use that to make I don't know how many millions of people having access to that at the cost, which will be accessible to our poor people, is not possible. And lastly, for me, and I stop there, let us not dream. If you don't have a regional hub of production, you're just joking. You cannot continue to think that you will produce in, I remember 15 years back, coming here when the President Mahama was vice president, and the first discussion we had in his office was local production. But I was coming from Benin, and the president of Benin was trying to produce IRV in Benin. And I took 2 hours by car to come in Lomé, and the president of Lomé I met wanted to produce IRVs. I came in Ghana, and we found Danada with the president trying to produce IRVs. I moved from here, I went to Abidjan, and the president said, why we don't try to produce IRVs? How, honestly, you can be competitive and you can really make the difference in terms of local production, vaccine, diagnostic, and therapeutic. So I think those are 5 lessons I learned, at least from my small experience. And if you add that to proper leadership, things will move.
Thank you so much. Yeah, I think for the communities, you have your teeth cut out for you at this session. There's brilliance, there's policy, there's financing, there's researches, but we have to move an agenda forward. While we hear that the space is closed, and believe me, there's so much more that we can do. If we as community once again go back to advocacy space, where we drive national agenda, make the government become a lot more responsible for the things they want to do. So Martin Mary, I want to believe that you're leaving here not by asking a question, but by going back to a constituency to drive an agenda that, yes, this is one of the key things, but we have not heard the voice of the community well in this space. On that note, I want to thank the panelists for the brilliant discussion. Personally, it's been brilliant. I really thank you, Benjamin, for being African CDC and responding, and he's my co-coordinator and moderator. Thanks for doing all that, in addition to being a panelist earlier today. Let's show appreciation to them as we leave the stage. Thank you very much. Over to the organizers.
We're done.